everyone, and welcome to Inside Healthcare. Summer is just around the corner, and in this program, we'll give you some tips on how to lose those final 5 or 10 pounds before Memorial Day. But first, we'll tell you about a very cool, first-of-its-kind medical residency program in the country. And to tell us all about it, we're very pleased to have back with us Dr. Will Nicholson. He's a hospitalist with St. John's Hospital and coordinator of the Preparation for Residency Program with the University of Minnesota Medical School. Glad to have you back with us.
Thanks, good to see you
And
again.
also joining us are two very special physicians that are with this program, Dr. Berto Torres on my right here, and then on my left we have Dr. Kim Adhikari. And thank you both for being with us as well.
Thank you
for having us.
So before we talk about this very incredible, cool program, Dr. Nicholson, maybe we can each take just a couple minutes just to tell us a little bit about yourselves. And Dr. Nicholson, you're a hospitalist, and some of your viewers may not have been at the hospital lately. Can you kind of tell us, what does a hospitalist do? What are they?
Well, I'm a family medicine trained physician, and I exclusively practice in the hospital. I grew up in White Bear Lake. I trained at St. John's Hospital, and when it came time to get a job, they were hiring doctors to just work in the hospital, to take care of the patients that were there. And so I'm basically the intermediary between the hospital and your primary care doctor. So if you have a doctor that doesn't go to the hospital, I take care of patients for that doctor, and then when you're discharged from the hospital, I send them the summary and the recommendations, and sometimes we chat on the phone if our schedules jive.
And that's really become the trend, right, to have hospitalists at not only at St. John's Hospital, but all the hospitals around Minnesota that didn't exist, 5-10 years ago?
Yeah, I trained to do sort of the old-fashioned doctor job of seeing your patients in the clinic, and then when they got admitted to the hospital, visiting them and rounding on them. But as hospital care has gotten more complicated and there are more financial pressures on both clinics and hospitals, we found that splitting up the duties has been more efficient. Now, who knows what the future brings. I still really like clinic and delivering babies and stuff, but right now I'm focusing on working in the hospital and then doing some teaching with the university with this program.
Okay, we're excited to hear about this program, but first, again, Dr. Torres, maybe you can tell us a little bit about yourself.
I'm a doctor from Cuba. I graduated from 1996. I practiced in Cuba over the last 15 years, in Venezuela too. I came to the United States in 2008, I'm sorry. I've been studying for the medical board. I came with my wife. I love Minnesota. I love Minnesotans. I'm glad to be here.
All right. And a little bit about yourself then too?
I'm Dr. Kim Adhikari. I'm originally from Bhutan. I did my graduation from India, and then I practiced my medicine in the refugee camps in eastern part of Nepal. I practiced most of the time primary care medicine in the refugee camps, and then 2 years back I came to United States, and now I am in the program of preparation for residency with the university, and trying to enter into a residency to practice the same medicine in United States.
Well, we're glad to have you both here.
Yeah,
so maybe you can tell us, Dr. Nicholson, about this residency program. It's one of the first of its kind in the country.
Yeah, the Preparation for Residency Program is a sort of innovative experiment in medical education that's run through the University of Minnesota Department of Family Medicine. And the way that I got involved was because, as we mentioned, I'm a hospitalist at St. John's, and Health East generously offered to be the training site for the hospital training that these guys do. This program started with the recognition that there are a lot of new communities in Minnesota, and a lot of those communities have a hard time accessing health care. In addition, these new communities have doctors that have come from their countries of origin, Bhutan, Cuba, Somalia, and they haven't been able to get those doctors trained into medicine so that they could go back and serve their own communities and certainly anyone else that needs help. So what we try to do is give them about 7 months of training, 1 month at the University of Minnesota learning about the culture of family medicine and healthcare in America, 3 months in an inpatient training, just the same kind that a medical student would get in America, and then 3 months in outpatient training doing the same sort of medical student-based training where they see patients, do examinations, discuss the patient with an instructor, and formulate a treatment plan. At the end of that, they get a little certificate from us, and it's sort of like trying out for the big leagues in baseball. We don't get them on the team, but we kind of help them get the ticket to go to the tryouts. They still have to apply to residency just like everybody else. They have to compete with all the other people. But we're trying to solve that problem of how do you get a job if you don't have any experience, and how do you get experience if you don't have a job.
Well, it's a catch-22, isn't it?
Yeah, I mean, these guys, they come here, they're talented, they've practiced for years, but they have no way to access medical education to sort of get oriented, get their boots on the ground, and figure out where to go. So what we try to do is give them that venue, and what we found is that they're very talented, they're passionate, and they're turning out to be very good doctors. So I'm very excited about the program.
Before we started, you were saying that both of you were at St. John's and St. Joe's recently, but now you're at a clinic. What brought you to the program, and why did you want to be a family doctor? Whoever would like to start?
Basically, I have been practicing primary care medicine in the refugee camps for the last 10 to 15 years, and I have been serving the community plus the local population. So when I came to United States, there are a good chunk of Bhutanese refugee community in Minnesota now, plus in other states also. So when I am among my community members, and what I have practiced since my early days in the refugee camps, so I would like to go back into the medical practice, do what I have been doing, and help the community that is, like as Dr. Will said, that the navigation of the healthcare system is inaccessible to these communities. So try to connect these resources with the community. Plus, it's not only with the community, but a lack of primary care physician in the United States, plus in Minnesota, and so many multicultural communities in Minnesota. So I think to solve that particular gap in between the communities and the medical healthcare facilities, I'd like to do what I have been doing.
What an awesome program to be able to help to serve the community as well as to be able to get you practicing here.
Yeah.
And for you, what brought you here, and why did you want to be a family doctor?
It's like Dr. Cam, it's a long way. I practiced in Cuba over the 15 years. I did internal medicine before, I did intensive care, emergency, and I went to Venezuela. In Venezuela, I started working in both sides, in intensive care, but some kind of primary care, in prevention more than any other thing. When I came to United States in 2008, I started the immigrant process, learning new language, everything, many skills that I didn't have before, that you need to have here to survive here. I started to study for the medical board. We took all the tests, all the exam, but at the end of the road, this part of the road is not enough. You need to have hand-on experience. You need to have experience interacting with patients in United States. Any kind of patient can be immigrant, but can be American too. That is the point. I compare my profession like the life. The life is the long trip. As intensive care, I work always at the end of this trip. I want to change. I want to be at the beginning, at the start of this trip. I think that we have too much results. Working in prevention, trying to that the people don't get sick, and that is my goal. It's for that I knew about the program. We applied. We went to a big selection, and we are glad to be here.
Oh, I bet
Many
you were
good
thrilled.
doctors, yeah.
Absolutely thrilled. Some of the challenges, I know last year there was some cuts made by the state legislature on funding for just the residency program or the MERC program in general, and that was also affecting this program. Maybe you can talk a little bit about that, Dr. Nicholson.
Yeah, I mean, it's pretty well understood that there's a primary care shortage in America. We don't have enough providers. My specialty is family medicine. We certainly don't have enough family medicine doctors. The need is growing as America's population ages, and the number of spots for training aren't expanding to meet that need, and in fact, in some ways, there are pressures to contract those. This is really counterproductive from my point of view, as three doctors who have really devoted ourselves to preventing disease and keeping people healthy rather than just waiting until people get sick and then taking care of them in the hospital. It's very frustrating. What happened last year is that in the budget crisis, the state decided to cut, I believe it was almost $1 billion from the Health and Human Services budget overall. Some of those cuts were hundreds of millions of dollars that fund the education of new doctors. And our program was one of those programs that got cut. Now our program we're small, we're streamlined. We try to make the most of all the resources we have. Our total budget is $150,000, but that was cut. Now, fortunately, we have a great network of support in the local communities, at the University of Minnesota, and at the hospitals and clinics that we work at Smiley's Clinic, where they're training now, as I mentioned, at Health East. And everyone, after we got our funding cut, said, hey, we're still there for you, let's figure this out. The University of Minnesota stepped up and fronted the money to continue the program. And because we all work together, we get a lot more out of that $150,000. That just sort of covers our superficial costs. Mm-hmm. If I was to put a cash amount on the amount of sort of generously donated time and facility space and free teaching that all these other programs, all these other medical education programs give PRP because they believe in the program, because they like these guys and they see that their communities need them, it would be probably 5-10 times as much.
You just wonder what the community did before this program even existed, and it's only been in existence a year? Something like that? Wow, that's awesome that you were able to get that funding reestablished. So what are some of the big challenges that you're facing? Dr. Torres?
Yeah. United States is a big challenge for me. A new language, a new no driver license. I learned to drive here. I learned to speak another language. I'm learning, I'm still learning. But beside that, you have the medical career. You need to study again. You need to study I studied medicine in 1990, maybe, almost 20 years ago. I need to study again, the medical school. But it's okay, you learn a lot. When you study for the second time, the third time will be better, I think so. But it's okay with us. But the point is that almost all the residency program in the United States, I think my guess is maybe more than 80% of the residency program in the United States. One of the requirements is to be graduated less than 5 years. That means that the experience for apply is not a good thing.
Oh,
and that,
didn't realize that.
Yeah, that take out all our possibilities to go inside the residency program. Doesn't matter score, doesn't matter many other requirements, but that requirement don't permit us go through the process, most of the time. This is an experience that PRP is giving us right now, give us the chance to meet them and let they know that we will do our best. Okay, we are working with our heart in this, and this is our goal. This is our mission here.
Oh, I bet the community is just very grateful to you and you as well.
Yeah.
So, Dr. Kim, what about you?
I think the greatest challenge that I faced, and most of my colleagues like me who have come to America as a result of political circumstances back home, would be like getting back into the system of medical career in United States. We have been practicing there for 10 to 15 years, but then when we come here, it's a totally new culture for us.
I can imagine.
And totally new circumstances, new communities. Of course, we have our own communities, but then since it's a multicultural place, we have to serve, or we have to be with other communities also. So the whole social dynamics of a family changes when you come here, and on top the pressure of getting back into the system with all steps, exams for licensure in United States, plus you have to support your family, and then like if you have kids, I have 2 kids, so we have to support those kids, my family. So the whole pressure of family plus professional life, and plus the pressure from the community that I was working there for last 10 to 15 years is also here. So they think that I'm still their doctor because I have been working with them, and they want me to come to them and then serve them, show them the way, show them how to navigate the thing because of the socio-cultural dynamics. But then they don't understand why I am not able to get into the system.
Wow.
So I cannot just explain these communities that, oh, now I am no more your doctor, because they have a faith and belief in me. And I want to keep up that expectations. I want to go back to practice, but then the challenge of getting into system, as Dr. Will said, that if you don't have something to work, you won't get the experience, and if you don't have the experience, you don't get into work. So the vicious cycle of this work and experience was bogging me up basically. And then like once we found out PRP as a program whereby we compete and then we clear our steps and we come here, we learn almost all the requisite of a residency program, and with that we'd be able to go and serve to the community. So the biggest challenge for me was to get into the system, to find a program like PRP whereby I can come. At present we are from 4 different countries. We are people from so many different countries, so many different cultures. We learn how to interact, we learn how to deal with the patients. It's not only my community that I'll be serving tomorrow. As a primary care doctor, I'll be serving all the communities. So I need to learn intercultural communications and intercultural taboo that is persistent in third world countries. So we have to tackle all those systems. So I think from that point of view, that was the challenge I faced. And once I got into this program, I think I am on the right track, and then probably in next few years I'd be able to get into residency and then come back to the career.
Hopefully.
We just have a couple of minutes left, so briefly, what are some of the maybe surprises about medicine here in the United States versus what you had back at home?
The biggest surprise that we found out here was the confidentiality issue. Back home,
Really?
Back home, what we intend to treat is the patient, of course, but the family too. It's not the patient that is the whole in charge of his illness. Sometimes if a patient is age old, then we have to go back to the family, and then family decides for the patient. As long as it's almost most of the time it's that way. That was one of the thing that we need to really concentrate on here. Plus the availability of resources. We are used to working in a resource crunch areas. Like we don't have so much of a facilities. We don't have labs and X-rays at all times.
Wow.
So we need to work on a basis of our clinical judgment. But when we come here, we have access to all these facilities, and then we don't know how to use all those facilities because we are tuned to a different system. So coming.
It's a nice problem to have, I suppose.
Coming in touch with the reality and the availability of resource is one of the things that we need to learn about.
Final comments about the program for you?
I am full of love and gratitude to Minnesotans and Minnesota. We come here as immigrants to give, as a taker. I have been taken for almost 4 years. I will love to come back and give all the love and all the hope that Minnesota had been giving me during all these 4 years. That's it. I think that I will love to work and serve to Minnesotans.
A quick comment I would like to add in this is that preparation for residency program has come out in Minnesota, which is a very unique program. They don't have any program like this throughout the United States. And this shows that the community in Minnesota they care about their population because they know that there is a lack of primary care doctors in Minnesota. They want to give the best of the facilities to the Minnesotans. That's why the program has come up as a result of this. Otherwise, there is a deficiency of primary doctors in other states also, but I cannot say that they are not willing to do that, but then, the sensitivity of the issue has come up in Minnesota, so that's a great thing that I came to know about Minnesotans.
Dr. Nicholson, final comment?
Well, it's hard to follow these guys. They have come a long ways to be doctors. They have traveled across countries, lived in homeless shelters and in refugee camps, and all the time that they've been there have tried to help people and treat people. And it's a privilege for me to meet them and learn from them. The standard that I set when I started going down this path was that I wouldn't graduate anyone who I wouldn't be comfortable sending my kids to. And so far they've all knocked that standard out of the park. They're fantastic doctors. They really deserve a chance to practice medicine, and I'm proud to be helping in a small way. When you compare our little program to what they've overcome already, it's nothing.
Well, it's really been a privilege to have all of you with us today, and appreciate it, and continued success and good luck.
Thank you so much.
Thank you so much
for having us.
Appreciate it. All right. And we, coming up next, some tips on how to slim down for the summer. Stay with us, everyone.
Where's my husband? Where's my husband?
We're in a stop.
How's she doing? 2,
She was the passenger. I was T-boned on the passenger side.
We just had some wine. I wasn't even drunk. I was just buzzed.
What? You were just buzzed. Well, sir, you didn't tell us that. In that case, she's just fine.
Yeah, I'm fine.
Really?
No, not really.
Buzz driving. Maybe we should stop acting like it's no big deal.
Welcome back to Inside Healthcare. We're pleased to have back with us Leanne Grayview. Thank you so much for being with us. She's a registered dietitian with St. John's Hospital and has the Lifelong Nutrition for Women program there at St. John's. So it's always a pleasure to have you back. So I know lots of people, summer's just around the corner, they're thinking, I've got these 5-10 pounds to lose. Could some of the things in their diet be sabotaging their efforts to lose weight? They're saying, well, I had a salad, or I just had a soda. I heard soda can increase your risk to obesity substantially, just even 1 to 2 glasses of it a day.
Right. With soda, you're consuming about 3 pieces of bread or 3 servings of fruit. So if you have a sandwich and a piece of fruit, and then you add to it a 250 calorie soda, it's basically like the same number of calories that you had in the sandwich and the fruit by adding that sugary beverage. When you consume a soda or a beverage that contains calories, your body doesn't really register that it's getting calories, so it doesn't know whether your body doesn't register.
It doesn't?
No, that let's say you drink a Slim Fast or a milk or a pop or a juice. It's really chewing, and salivating and creating digestion through solid foods and fibers that satiety signals are registering. Whereas when you just drank 20 ounces of fluid, it does help your satiety in some way by making you feel full a little bit. Yeah. But it really doesn't tell your body that you just received some calories. So you basically are doubling up your calories in your meal by having a soda. And fruit juices sound healthy, but those too can be
Right, and
industry is coming out with a lot of juices now that are reduced in calories. We've got the Trop 50 in the Orchard Farms, reduced calorie juices, Ocean Spray, V8 Splash. They all come in a sugar-free variety. A lot of people, for example, use cranberry juice when they have urinary tract infections or for their urinary system. But if you're a diabetic and you're more likely to have a urinary tract infection and you're consuming lots and lots of cranberry juice because you heard that it's good for you, those sugar babies that is in the juice is only contributing to the infection rather than helping to cure it. So I usually recommend a sugar-free variety, and they have a lot of low-calorie juices on the market. However, if you switch to juice from soda, considering that it's better for you, it still has the same calorie density, which is about 10 to 15 calories per ounce.
Wow. What about wraps? They're very popular right now. Can those also be helping, sabotaging your efforts to try to lose weight, or can they be useful to help you to lose weight?
Well,
replacing them with the sandwich that you might normally get.
Sure. Usually for women, I suggest about 3 sources of carbohydrate, which is either coming from your milk or your fruit or your grain or a starch item. So if you have a large wrap, and you were telling me that sometimes the carb count is as much as 3 slices of bread in a wrap, if you're going to choose a wrap and you're purchasing at the store, look for the high fiber content. A lot of them have whole grains or flax in them, so that the fiber content is the part of the carbohydrate that doesn't get absorbed. So really it can take the carbohydrate content and put it right in half if you remove the fiber, which is the part, it's counted in the carbohydrate, but let's say it has 18 grams of carbohydrate, but then it also has, let's say, 8 grams of fiber. Now you're really only getting 10 grams of carbohydrate. So if you're going to choose a wrap, or you're purchasing a wrap, get the ones that are really high in fiber, that have a lot of added seeds or flax to it.
So if there's 1 or 2 things that someone can do to try to take 5-10 pounds off before summer hits, what would you recommend?
I would say, let me give you an example of one of my clients. I made a suggestion that, since we can't get out to the gym every day, or the weather is bad, or we have reasons in our schedule that we can't go to the gym, on the off days, I suggest doing a step. Just take an aerobic step, or a step that you have at home that's sturdy, and while you're watching your program, for 3 minutes, step up onto the step, which is 6 or 8 inches off the ground, and step off the step very slowly. When we teach it in the class setting, we use a metronome so that people don't do it too quickly. It doesn't involve any twisting, or you don't have to get into a leotard to do it. You're doing it right in front of your program. And then rest during the commercials. And by the time a half-an-hour program is over, you've done 15 minutes of stepping. And I'd like to quote one of my clients who lost 16 pounds in 3 months, which is kind of what you're hoping for before the onslaught of summer. And the main thing that this client did was actually do what I suggested, which is the step every day.
And that's
faithfully.
all she did differently?
This was a male.
Yeah.
This is a male, and of course, he made a few changes in his snacking pattern, but actually, so often when I make suggestions to my clients as a dietitian on an outpatient basis, people say, well, I'll try, or I'll think about it. But the difference here was this person actually did it, and was very successful in a short period.
Well, I'm afraid we're out of time, Marianne. Thank you. Great information as always. And if they want more information about your program, they can go to the website?
Right, Lifelong Nutrition for Women, and that offers a benefit of going to see the dietitian as an outpatient without having to get a doctor's referral at a reasonable price.
All right, thank you.
Thank you.
Appreciate you being here. And we appreciate you being with us. Hope you can join us next time at Inside Healthcare. We'll see you then, everyone. Thanks.
Inside Healthcare. For more information, visit stjohnshospital-mn.org or call 651-326-7800.